Good morning, everyone. I would like to thank the organizers for including me in this national symposium on pediatric ophthalmology. I'm talking on current concepts in the management of small deviations like mini tenotomy, partial tenotomy, mini plication, etc. See, small angle deviation refers to deviations less than 10 prism diopters. Non-surgical management with prisms, Botox, etc. are there, but there are some surgical procedures also to take care of small deviations like partial tenotomy, mini plication, etc. Mini tenotomy is a minimally invasive surgical technique that weakens the rectus muscle to produce a correction of about 4 to 8 prism diopters. It's an alternative to wearing prism glasses developed by Kenneth Wright. So this is the diagrammatic representation of mini tenotomy. The central 2 to 3 millimeters of the rectus muscle is cut off. So indication for mini tenotomy is almost a very small deviation or a residual deviation after standard surgical procedure. In cases of sensory microstrabismus and macular diplopia, following an epiretinal membrane correction, this is a very good option. Remember that in vertical squints, fusion amplitude is very small, and small vertical deviations can result in double vision and asthenopic symptoms. So this surgery is of use there. Nowadays, we see a lot of macular diplopia due to epiretinal membrane peeling, and in such conditions, a central mini tenotomy is very effective. See, this patient has got a small left hypertropia, and because of this is an engineering student. He finds difficulty in looking at the listening to the professors because on looking up there is a hypertropia. In such patients, we can do mini tenotomy on the vertical recti, that's the superior rectus. And this procedure is done under topical anesthesia and can be done as an outpatient procedure. And the important thing is you have to identify the superior rectus muscle. With the forceps, you get hold of the rectus muscle and pull on the rectus muscle so that make sure that the entire muscle is in your forceps and not the fascia alone. And after you make sure that the muscle is in your hand, you can do a small mini tenotomy by cutting the portion of the muscle between the forceps and the sclera. This is done transconjunctivally. You don't have to expose the conjunctiva. And after making such a cut, you just see the area. Make sure that the two pillars of the muscle at the either end is remaining there, and the central area of the muscle is retracted. And at this point of time, you can now see the two pillars of the two muscle on either side, and a central area where the muscle has retracted. Now we go ahead, do the cover test, see whether your correction is adequate, and if the correction is not adequate, come back and do a few more snips, and there is no need of any suturing. And now come to the partial tenotomy. This is usually done in mild horizontal strabismus, especially those cases in which there is a primary position orthotropia and up and down gaze there is a small deviation. These patients will present with asthenopic symptoms. This is the diagrammatic representation of partial tenotomy popularized by Alan Scott. Again, I'll show you the surgical video in partial partial tenotomy. Again can be done under topical anesthesia. You identify the muscle. I'll just fast. And after identifying the muscle, you can cut. You can make a small cut like that. And after making a cut close to the insertion, again go ahead, do the cover test. If there is any undercorrection, you can cut a little more of the muscle. Up to 90% can be cut. This can be done in both the eyes. I'll show you the picture. This is a child who presented with a primary position orthotropia, but on down gaze there is an exo, and because of that the child had asthenopic symptoms on reading. The child was not able to concentrate on reading books and was not doing well in school. So we did a partial tenotomy. And post-operative picture, you can see that there is no overcorrection, no undercorrection. An optimum correction is possible. And so in mild to moderate AV pattern with straight or almost straight eyes in the primary position and a deviation in up or down gaze, you can do a partial tenotomy. And a few strengthening surgeries also are there to correct small deviation. This is mini plication, in which small conjunctival incision is made over the muscle. The muscle is grasped and a suture is put just like you see in the picture, and then the suture is advanced to in front of the muscle onto the sclera, and it is tightened to produce mini plication. Similarly, there is an mini angled resection also, just like what you see in this photograph. A suture is passed from the center of the insertion to 5 millimeters behind, and the triangular area is excised, and the suture is advanced and brought forward. And this is also published. And I would like to conclude saying that management of small angle strabismus is very challenging, and these patients may have significant asthenopic symptoms and diplopia, and conventional procedures often lead to overcorrection. And such new several procedures are now available, and this can be done under topical anesthesia, and this is an alternative to prisms. All these patients can be treated with prisms, but the difficulty is that they have to have a lifelong spectacle wear. So those people who are already wearing spectacles, you can give prisms. Those people who are not wearing spectacles, this is a very good option. With that, I conclude my talk. Thank you, AIOC. Thank you for patient hearing.